Hi everyone. So we're going to be going over caring for clients with head and spinal cord trauma. So when we're talking about spinal cord trauma, we're talking about damage or trauma to the spinal cord that can cause temporary or permanent loss of motor function. This also includes sensation, reflexes, and even bladder and bowel control. So the most common causes of spinal cord injury are motor vehicle accidents, falls, violence, and sports injuries. And young men ages 16 to 30 are at the greatest risk for spinal cord injury. Also, neurologic damage depends on the extent and location of the injury. I just want to make a quick note that when we're talking about spinal cord injuries, there's primary injury and secondary injury. So primary injury is trauma leading to cord transection, which is complete or partial, compression, traction, or loss of blood supply. But if we're talking about secondary injury, this is progressive damage that occurs following the primary injury. So this can include hemorrhage, ischemia, hypoxia, and edema that may lead to permanent damage. So before we start talking about all the things that have to do with spinal cord trauma, we need to know that the prognosis for spinal injury is most accurately assessed 72 hours after the initial trauma because of secondary injury. All right, let's get into objectives. So in this slide, you're going to be able to differentiate a concussion from a contusion. You're going to be able to explain the cause and effects of chronic traumatic encephalopathy. You're going to be able to identify differences between epidural, subdural, and intracerebral hematomas. You're going to be able to discuss the nursing management of a client with a head injury, discuss the nursing management of a client undergoing intracranial surgery. You're going to be able to explain spinal shock, listing 4 different symptoms, discuss the autonomic dysreflexia and at least 5 manifestations, list possible long-term complications of spinal cord injury, describe the nursing management of a client with a spinal cord injury, and finally, we'll be able to identify the anatomic difference between intramedullary and extramedullary spinal nerve and root compression. Okay, so let's talk about different head injuries. So an injury to the head can cause concussions, contusions, hematomas, or skull fractures. Right now, we're going to talk about concussions. So a concussion results from a blow to the head that jars the brain. And it's usually a consequence of falling, striking the head against a hard surface, such as a windshield, colliding with another person. So this can happen like between athletes, battering during boxing, or being a victim of violence. So a concussion causes diffuse and microscopic injury to the brain. So it's like very small and minute, but the force of the blow causes temporary neurologic impairment, but there's not necessarily any immediate evidence of serious damage to cerebral tissue. So the thing is, when concussions occur repetitively over and over, even though the blows to the head may appear initially to have like very small, minute, very non-significant effects, they can result in chronic traumatic encephalopathy. And this is a form of neurodegeneration. So cumulative and sustained concussions, such as those that are sports related. So think like football players that get concussion after concussion because they get hit over and over. It can result in a long-term effect such as dementia, depression, Parkinson's disease, and early onset Alzheimer's. So let's go into assessing somebody with a concussion. So when somebody gets a concussion, they might have a quick lapse of consciousness, maybe some disorientation. They might have headache, blurred vision. They might be emotionally irritable, and they might be a little bit dizzy. Now, a diagnosis is made clinically because there are no proven biomarkers that are evident in screening tests. What that means is we can't really do a test to test if they've had a concussion. the only way we can assess if they've had a concussion is base it off the signs and symptoms. We can do skull radiography, CT scans, MRI scans, and that can rule out a more serious head injury, such as a skull fracture or intracranial bleeding. But it may show reduced blood flow to the brain when it's performed later. So, in the years that follow, there might be some behavioral changes, memory and cognitive dysfunction, movement disorders, and increased suicidality. So, when somebody gets a concussion, we make sure that the activity is stopped. So, whatever they're doing, we want to stop that until we can determine the seriousness of their concussion. We can use mild analgesia, so maybe usually Tylenol, acetaminophen, that will relieve the headache, and they're generally observed over the course of his or her lifetime for neurologic complications. For nursing management, we are going to do a neurologic assessment. And if the findings are normal and the client doesn't require hospitalization, then we'll instruct the family to watch the client closely for signs of increased intracranial pressure. So, common signs of increased intracranial pressure include behavioral alterations, sleepiness, personality changes, vomiting, speech or gait disturbances. And the nurse is going to instruct the client and the family to contact a doctor or return to the emergency room if any of these symptoms occur. So let's talk about a contusion. So a contusion is way more serious than a concussion, and it can actually lead to structural injury to the brain. Now, a contusion results in bruising and sometimes hemorrhage of the superficial cerebral tissue. So when the head is struck directly, the injury to the brain is called a coup injury. But dual bruising can result if the force is strong enough to send the brain ricocheting to the opposite side of the skull, which is called a contracoup injury. Now, we can get edema, swelling, which develops at the site of or in the area opposite to the injury. And we can also get a skull fracture that can accompany a contusion. So when we are assessing for somebody that has a contusion, it depends on how severe the blow was and the degree of head velocity at which they got the contusion. So some of them might have hypotension, a rapid and weak pulse, shallow respirations. They might lose consciousness. They might be pale and clammy. The ones that are sometimes unconscious, they still usually respond to strong stimuli, like, pressure being applied to the base of the nail. And then sometimes when they wake up, some of the clients might have temporary antegrade amnesia. Now, temporary antegrade amnesia means that they either have partial or a complete inability to recall the recent past, so they might not be able to remember how they got in the accident, right? Or they might have memories from before the traumatic event that remain intact. Permanent brain damage can also happen, and this can impair their intellect, their gait. They might have difficulty with speech. They might have seizures and even paralysis. So in order to diagnose for a contusion, we do skull radiography, which is performed to rule out or confirm a skull fracture. And then we can also do a CT or an MRI, which detects bleeding or small hemorrhages in the brain tissue, a shift in the brain tissue, and edema or swelling at the injury site. Question number 1. Is the following statement true or false? Contusion assessment findings include hypertension, rapid weak pulse, shallow respirations, and pale, clammy skin. False. A contusion includes hypotension, rapid weak pulse, shallow respirations, and pale, clammy skin. So for medical management for a contusion, we're just really monitoring their vital functions, and we might support this with drug therapy and even mechanical ventilation if necessary. What we will do is we're going to observe the patient closely for any changes in level of consciousness. We want to watch out for signs of increased intracranial pressure. We want to see if there's any neurologic changes, respiratory distress, and we're going to want to see if there's any changes in vital signs every 1 to 2 hours. Now, if the symptoms do develop, we do have to report them to the doctor. So prevention of health problems is a major component of nursing care. So to reduce the potential for both minor and life-threatening head injuries, the nurse is going to really stress the importance of using seatbelts for all passengers in the car, restraining infants in approved car seats located in the rear seats of cars, wearing protective headgear while riding bicycles, motorcycles, skiing, and any contact sports such as hockey, baseball, football, or softball. Also, we want to make sure we educate that we are going to raise neck restraints on the back of car seats, and we want to make sure we're educating them to not drive under the influence of alcohol or drugs. Question number 2. Is the following statement true or false? Concussion is a blow to the head that jars the brain. True. Concussion is a blow to the head that jars the brain and is a temporary neurologic impairment. So let's talk about cerebral hematomas. Now, a cerebral hematoma is bleeding within the skull, and the accumulation of blood forms an expanding lesion. And people at high risk for cerebral hematomas are those receiving anticoagulant therapy or those with an underlying bleeding disorder, such as hemophilia, thrombocytopenia, leukemia, and aplastic anemia. So, most hematomas result from head trauma or cerebral vascular disorders. The types of hematomas are epidural hematoma, subdural hematoma, and intracerebral hematoma. So if you go to page 675 of your MedSurg book, on figure 39-3, you're going to be able to see a picture, and it will more visually help you to see what a subdural hematoma is, an epidural hematoma, and an intracerebral hematoma. So an epidural hematoma stems from arterial bleeding, and that's usually from the middle meningeal artery and blood accumulation above the dura. So this is characterized by rapidly progressive neurologic deterioration. A subdural hematoma results from venous bleeding, and blood gradually accumulates in the space below the dura. Subdural hematomas are classified as either acute, subacute, and chronic according to the rate of neurologic changes. Symptoms will usually progressively get worse in a client with an acute subdural hematoma within the first 24 hours of head injury. Usually patients with a subacute and chronic subdural hematoma become symptomatic after 24 hours and even up to a week later. An intracerebral hematoma is bleeding within the brain that usually results from an open or closed head injury or from a cerebrovascular condition such as a ruptured cerebral aneurysm. So, bleeding will increase the volume of brain contents and intracranial pressure, and this disrupts the blood flow and causes the brain to become ischemic and hypoxic. Now, if we have unrelieved increased intracranial pressure, this also causes the brain to shift to the lateral side, and this is called uncal herniation, or it'll herniate downward through the foramen magnum. Now, when this happens, these developments will affect the vital centers for respiration, heart rate, blood pressure, as well as cranial nerve functions. Death will occur if the symptoms aren't recognized and if the bleeding is not controlled. So we really have to pay attention to this. So when we are assessing the cerebral hematomas, right, it kind of depends on how rapid and severe the neurologic changes have happened depending on the location, the rate of bleeding, and the size of the hematoma, and the effectiveness of autoregulation, which is the brain's ability to provide sufficient arterial blood flow despite rising intracranial pressure. We can do MRI and CT scans, which will show densities that indicate the location of the hematoma and shifts in the cerebral tissue. What we really want to do is we want to monitor for intracranial pressure and provide direct and continuous data for evaluating where the lesion is expanding and responding to treatment. So when we're assessing, right? So, okay, the epidural hematoma is the location that it's at is that the arterial blood collects between the skull and the dura, right? So this means that the patient may be alert after maybe being unconscious for a minute, but then they will become increasingly lethargic before lapsing into a coma. Some of the common symptoms for an epidural hematoma are a headache, ipsilateral, which means the same side as the injury, so ipsilateral pupil changes, and contralateral, which is the opposite side of the injury, hemiparesis. So basically, if they were hit on the right side, right, then if they have pupil changes to their right eye, and then they have hemiparesis to the left side of their body, that could be indicative of an epidural hematoma. For a subdural hematoma, this means that venous blood collects between the dura and the subarachnoid layers, right? So the signs and symptoms you would see in this is a deterioration in the level of consciousness, and it happens to be very progressive. And then you'll have pupil changes on the same side that they had their head injury. They'll have decreased extraocular muscle movement, contralateral hemiparesis, and periodic episodes of memory lapse, confusion, drowsiness, and personality changes. Now, in an intracerebral hematoma, this means that blood collects within the brain, right? So this means that the patient's going to show classic signs of increased intracranial pressure, which would be headache, vomiting, seizures, posturing, hyperthermia, and irregular breathing. So sometimes the body will wall off and absorb a subdural hematoma without any treatment. But if there is a rapid change in the level of consciousness and they have signs of uncontrolled increased intracranial pressure, this means that it is a surgical emergency. So let's talk about surgical management. So surgery for these hematomas consists of drilling holes, which are called burr holes in the skull, and this is known as trephining, which means relieving pressure, removing the clot, and stopping the bleeding. If the source of bleeding cannot be located by the means of the burr holes, then more invasive surgery is performed. Epidural hematomas require a more prompt intervention because the rate of bleeding is a lot greater from an arterial bleed than from a venous bleed, right? So intracranial surgery consists of 3 possible procedures. We have a craniotomy, a craniectomy, and a cranioplasty. So a craniotomy is a surgical opening of the skull to gain access to structures beneath the cranial bones. It's used to remove a blood clot or a tumor. We can stop intracranial bleeding or repair damaged brain tissues or blood vessels. A craniectomy is a removal of a portion of the cranial bone. Cranioplasty is the repair of a defect in a cranial bone. So the portion of the bone removed during craniectomy may be implanted in the client's abdomen until later replacement. So as an alternative, a metal or a plastic plate or even a wire mesh can be used to replace the removed bone or to reinforce a defect in a cranial bone. So there's one of 2 surgical ways to enter the brain, above or below the tentorium, which is a double fold of dura mater that separates the cerebrum from the cerebellum. The supratentorial, which means it's above the tentorium. So A supratentorial approach is made through a scalp incision at the site where a particular cerebral lobe requires surgical access. The infratentorial, which means it's below the tentorium, this approach provides an opening to the midbrain and structures to the brainstem. The incision is made at the very back of the head with the client in a sitting position. So as you can see in this picture, this shows that in picture A, that's a supratentorial incision that's made behind the hairline of the site of pathology, whereas B is the infratentorial incision, which is kind of in a horseshoe shape around the occipital lobe. So in cranial surgery, after there's some burr holes that are made in the skull, a saw will be used to cut a section of the bone, and this is called a bone flap. Now, the bone flap is removed to provide a visual field of surgery, and once the surgery is complete, the bone flap can usually be replaced. In some instances, such as with an inoperable tumor, the bone flap isn't replaced, and that allows the tumor to expand and reduce the rate at which intracranial pressure may rise. Some of the complications that can be associated with intracranial surgery can be cerebral edema, infection, neurogenic shock, fluid and electrolyte imbalances, venous thrombosis, especially in the arms and legs, increased intracranial pressure, seizures, leakage of cerebral spinal fluid, and stress ulcers and hemorrhage. So we as nurses will always regard a head injury, no matter how mild it seems to us or to anybody else. We're always going to treat it like an emergency. So we need to obtain the history of the injury. We're going to perform a neurologic examination, pay very particular attention to vital signs, level of consciousness, whether or not there is maybe presence or absence in the movement of their arms and legs, their pupil size, acuity, and their reaction to light. If there was any trauma caused by the head injury, we're going to look at the head for bleeding, abrasions, lacerations. We want to pay attention to their respiratory status, and we want to make sure that they're able to maintain adequate oxygenation. We want to make sure that we're going to report any neurologic changes immediately, and we want to care for clients with increased intracranial pressure and treat them immediately. So depending on whether or not the doctor deems it necessary for surgery to occur, we as nurses are going to be prepared. So we may have to use electric hair clippers to remove hair where the burr holes will be drilled, or where incisions may be made. We're going to want to make sure we take vital signs, maintain a record of continuing neurologic assessment findings. We're going to administer any prescribed medications. So medications such as phenytoin, and that's phenytoin is Dilantin. This is going to reduce the risk of seizures before and after surgery. We can give osmotic diuretics and corticosteroids. So pre-op sedation is usually omitted, so we don't do it. Before surgery, the nurse will restrict fluids to avoid intraoperative complications. We're going to want to reduce cerebral edema and prevent post-op vomiting. If it is indicated, then we can always do an indwelling urethral catheter and an IV line. We're also going to want to make sure we apply anti-embolism stockings to prevent thrombophlebitis and deep vein thrombosis, and this can develop from prolonged inactivity during neurosurgery. Now, keep in mind that some medications that we give, such as diazepam or Dilantin, can actually injure soft tissue if the IV solution is leaked out of the vein. So we have to make sure that we have supplies and protocols for treatment when these IV drugs are used. So let's go over post-op nursing care. So after surgery, we're going to place the patient in a supine position with the head slightly elevated or a side-lying position on the unaffected side and perform post-op and neurologic assessments every 15 to 30 minutes. Now, we maintain a neurologic flow sheet to compare trends and assessment findings. This makes it visually a little bit easier for us to see when their vitals have changed even slightly. We can look for periorbital edema, and that's edema around the eyes and pupils difficult during the immediate post-op period. That can make it difficult. We can also see ecchymosis. You're going to want to remove anti-embolism stockings briefly every 8 hours and then reapply them. We also want to monitor the client's body temperature, because hypothermia can increase the brain metabolism, which increases the potential for brain damage. Therefore, the elevated temperature must be relieved with antipyretic and other measures. So we really want to keep a close eye for increased intracranial pressure and restrict fluids to control cerebral edema and increase cerebral perfusion. So you're caring for two clients with head injuries. Client A lost consciousness, and at the time of his head injury, he was alert and oriented on arrival to the emergency department. But 2 hours later, he does not respond even when you press on his nail beds. Client B has been hospitalized for 1 day. He has not been fully alert since admission and continues to be lethargic. He requires more and more stimulation to obtain a response. Which client's condition is more serious? Explain your response. Alrighty, so let's go over skull fractures. A skull fracture is a break in the continuity of the cranium. So the most common types of skull fractures are simple, depressed, or comminuted fractures. So a skull fracture will result from a blow to the head. Now, this can be associated with an open head injury in which the scalp, bony cranium, and the dura mater are exposed, or it may be a closed head injury in which an intact layer of scalp covers the fractured skull. So a simple skull fracture is a linear crack and there's no displacement of the pieces. As you can see in the picture on the left, you can see that the simple one is just a line, right? And then in the depressed skull fracture, there's a broken bone pushed inward towards the brain. And that's going to be the top one on the left side. So you can see that it kind of concaves in, right? And then we have the comminuted skull fracture, and that's bone splintered into fragments. And that's the one that's a little bit lower to the forehead. So that one's below the depressed fracture in the picture on the left-hand side. Now, open head injuries can create a potential for infection because they expose internal brain structures to the environment, which never happens, right? And so that means that they're less likely to produce rapid increased intracranial pressure because the opening gives the brain some room to expand as pressure increases. So there's something called basilar skull fractures, and this is located at the base of the skull. So that's near our neck in the back. Now, trauma in this location is especially dangerous because it can cause edema of the brain near the origin of the spinal cord. And that interferes with circulation of cerebrospinal fluid, and it can injure nerves that pass into the spinal cord and create a pathway for infection between the brain and the middle ear, which can result in meningitis. So when we have a simple skull fracture, there's usually not very many, if any, symptoms, and they can usually heal without a complication. These clients that have a simple skull fracture will usually complain of a localized headache. They'll usually have a bump, bruise, maybe a laceration that's visible on the scalp, and the symptoms kind of depend on the area of the brain that's been injured. So for example, if there's a large bone fragment that's pressing on the motor area, this can cause hemiparesis, so weakness on one side. In any type of skull fracture, shock can develop from injury to the skull or some area of the body. Now, when we're talking about basilar skull fractures, this can tend to tear the dura, and you can get rhinorrhea, which is leaking of the cerebrospinal fluid from the nose, or we can get otorrhea, which is leakage of cerebrospinal fluid from the ear. In some cases, we might get periorbital ecchymosis, and this is referred to as raccoon eyes, or bruising of the mastoid process behind the ear, which is battle signs. So if you look on page 682 of your MedSurg book, you can see the rhinorrhea. So it literally just looks like blackness in your eyes. So you know how when a girl kind of rubs eyeliner all over her eyes, right? That's kind of what it'll look like. Battle sign is a little bit different because it's a bruise behind your ear, and this is very indicative of a basilar skull fracture. We can also get conjunctival hemorrhages, and injury to the brain tissue may also result in seizures. And then we can also get epilepsy that can develop as a sequela of head injury. So in order to diagnose for these kind of skull fractures, we're going to do skull radiographs, CT scans, MRIs, and this shows that brain tissue injuries such as fracture lines or embedded skull fragments, cerebral edema, subdural or epidural hematoma. So in order to medically manage a skull fracture, simple skull fractures require bed rest, and we're going to closely observe them for signs of increased intracranial pressure. But if a scalp is lacerated, then we're going to clean the wound. We might debride it and suture it. Depressed skull fractures will require a craniotomy to remove the bone fragments and control bleeding, elevation of the depressed fracture, and we're going to want to repair the damaged tissues. We might insert a piece of mesh to replace the bone fragments that were removed, and we might include antibiotics to control infection, an osmotic diuretic to prevent or treat cerebral edema, an anticonvulsant to prevent or treat seizures. We can also use corticosteroids following head injuries and neurosurgery, but this is prescribed less and less because research studies are showing that there's a higher incidence of deaths as compared with those not treated with corticosteroids. So that's good to know, right? So usually patients are going to be hospitalized for at least 24 hours after a significant head injury. We're going to want to examine the patient to identify signs of head trauma and test the drainage from their nose or their ear to detect if there's any CSF drainage. We're going to want to look for something called a halo sign, and that's a blood stain surrounded by a clear or yellowish stain. And if this drainage is present, the nurse is going to allow it to flow freely onto porous gauze, and we're going to want to avoid tightly plugging the orifice. We also want to do neurologic assessments, and that's going to include an hourly evaluation of their level of consciousness. We're going to want to monitor their pupil response, motor response, sensory status, even if the head injury seems mild. Now, it's possible for a hematoma to accompany a skull fracture, so we have to get vital signs every 15 to 30 minutes and prepare for the possibility of seizures. Alrighty, so let's go into spinal cord injuries. Now, spinal cord trauma is serious and sometimes it can be fatal. The cervical and lumbar vertebra are the most common sites of injury. Now, correct emergency management at the time of injury is very crucial because moving the client incorrectly can permanently damage the spinal cord and the nerves that extend from it. So, common causes of spinal cord injury include accidents and violence. So vehicular accidents, including those involving motorcycles, are usually the leading cause. Then it's followed by violence, falls, sports, and then random miscellaneous injuries. Now, trauma to the back can fracture or collapse one or more of the vertebrae, and this can cause a portion of the bone to injure the spinal cord and interfere with the transmission of nerve impulses. So Even without a fracture, the swelling may actually lead to cord compression, and that can permanently damage the cord. So, spinal cord injury can also lead to bleeding within the cord. So, because the blood has no place to drain, it'll form a hematoma, and that will occupy the space and compress the nerve roots. Injury to the cord can also completely or partially sever spinal cord nerve fibers. And with this kind of injury, the client experiences various consequences of motor and sensory dysfunction below the site of the injury, and that can affect functional abilities. So we can get something called tetraplegia, and this is a term that replaces quadriplegia. So tetraplegia refers to weakness, paralysis, sensory impairment of all extremities and the trunk when there is a spinal injury at or above the first thoracic vertebrae. So that's T1. Paraplegia is weakness or paralysis and compromised sensory functions of both legs and the lower pelvis, which occurs with spinal injuries below the T1 level. Now, when the tract of the spinal nerves are completely severed, no effective nerve regeneration will occur. And what you'll get is you'll get these like muscle spasms that occur spontaneously, but they're not evidence that the client is regaining motor function. Many paraplegics will go home, live independently, and resume work. Tetraplegics may return home, but they require a lot more extensive physical care. Okay, so let's talk really quick about the complications that happens from spinal cord injury. So sometimes with spinal cord injury, they may go into respiratory arrest, spinal shock, and these are immediate complications of spinal cord injury. Some long-term complications include autonomic dysreflexia, pressure ulcers, respiratory infections, urinary and fecal impairment, spasticity and contractures, weight gain or loss, calcium depletion, urinary calculi, sexual dysfunction, and pain. So let's talk really quick about each of these things. So spinal shock is a loss of sympathetic reflex activity below the level of injury within 30 to 60 minutes of a spinal injury. This is characterized by an immediate loss of all cord functions below the point of injury. So in addition to paralysis, the symptoms that they have are hypotension, bradycardia, warm and dry skin. So if the level of injury is in the cervical or upper thoracic region, respiratory failure can occur. Then they can get bowel and bladder distension, and the client actually won't perspire below the level of injury, which means that this is going to impair their temperature control. So what they have is something called poikilothermia, and that's body temperature of the environment. Then there's autonomic dysreflexia, and this is hyperreflexia. This is an exaggerated sympathetic nervous system response in people with spinal cord injuries above the T6. This can occur suddenly at any time after the spinal shock subsides. So some of the characteristics of an autonomic dysreflexia is an acute emergency. So some of the things you're going to see is severe hypertension, slow heart rate, pounding headache, nausea, blurred vision, flushed skin, sweating, goosebumps, nasal stuffiness, and anxiety. So we have to remember that autonomic dysreflexia, when it's uncontrolled, it can lead to seizures, stroke, and death. So prevention is the best treatment, but we have to do additional measures such as administering antihypertensive drug therapy with nifedipine, nitroglycerin ointment, Retigine, hydralazine, diazoxide, raising the client's bed, and relieving the precipitating cause once it develops. So those with spinal injuries can get pressure ulcers. So 39% of people with spinal cord injuries will actually develop pressure ulcers in the first year following their surgery, and 34% will require 3 or more hospitalizations because of their pressure ulcers. Then we have respiratory infections. Now, people with spinal cord injuries, they might not be able to breathe normally and cough sufficiently. So what will happen is the spinal nerves that transmit impulses to the diaphragm, their intercostal muscles, neck and abdominal muscles, they no longer function. So the risk of inadequate ventilation and the risk of getting pneumonia is very high for them. We also have urinary and fecal impairment. So the kidneys continue to produce urine, but the muscles of the bladder and the sphincter, they might not be able to be controlled voluntarily. So this is what'll happen is like reflexive emptying when the bladder fills, or there's like a failure to empty, which causes the urine to reverse fill the ureters, and then the kidney will actually make the bladder become overly distended. And that means that the bacteria is likely to colonize the bladder because the client cannot completely empty it. And then there is spasticity. So clients with spinal cord injuries will experience intermittent spasticity. So this is uncontrolled jerking movements, muscle stiffness, and rigidity. And spasticity occurs because the nerve signals between the brain and the nerves below the level of injury are interrupted. So instead of it being coordinated, there's like this unregulated spinal reflex that'll cause an overly active muscle response. And so the muscle spasm will then pull the joint into a shortened position and increase the potential for skin impairment and contractures. So some with spinal cord injuries might get contractures, and this results from the inability to remove a joint freely because of the imbalance between opposing muscle groups. They might have some weight change, and they generally tend to lose weight, but then they'll gain weight after weeks, months, and years of inactivity. So we have to make sure that we're educating them on healthy food choices that are relatively low in calories and nutritious. We have calcium depletion. Usually after a spinal cord injury, they'll experience a demineralization of their bones because the physical activity is one mechanism for maintaining the bone density. So the loss of muscle force will contribute to bone demineralization. So about 80% of those with spinal cord injuries actually have osteopenia, which is lower than normal bone density, or osteoporosis, which is excessive loss of calcium from the bones. This means that they are at a higher risk for fractures from falls and even activities of daily living, as well as the consequences of the hypercalciuria, such as renal and bladder stones. This leads us to urinary calculi. So they are at risk for forming calculi, which are stones in the kidney or bladders, because they don't move quite as much, right? They're on prolonged bed rest. So what'll happen is they'll get stone formation. Then we get sexual dysfunction, and sexuality is kind of affected differently in the males and females who sustain spinal cord injury. So in most males whose S2 to S4 spinal nerves are undamaged, there's an involuntary reflex erection that can occur as a result of touching the penis or stimulating other erotically sensitive areas. There's also something called psychogenic erections that can depend on the level and extent of the spinal cord injury when males experience an arousing thought. Then we go into pain. So people with spinal cord injuries may actually experience one or more types of pain. They can experience neuropathic and nociceptive. So neuropathic pain will develop in approximately 66% of those with a spinal cord injury. And this is caused by an abnormal communication between spinal nerves and the brain. And it's described as sharp shooting, burning, stinging, tearing, bursting, and stabbing. Some experience allodynia, and that's a pain from a stimulus that doesn't normally cause pain. And then they have hyperalgesia, which is an increased response to a stimuli that was normally a little bit painful. So neuropathic pain is long-lasting and difficult to treat, so we have to make sure that we provide them with the right pharmacotherapy. So in spinal cord injuries, we're going to do radiography, myelography, MRIs, and CT scans. So when we are assessing somebody with a spinal cord injury, the degree and location of the spinal cord injury will kind of determine the immediate symptoms. So if there's pain in the affected area, difficulty breathing, numbness, paralysis, we have to determine if the injury is high in the cervical region. Respiratory failure and death can occur because the diaphragm can be paralyzed. So if the cord is completely severed, permanent loss of function below the level of injury can actually occur. If damage to the cord is minimal, then some function might be maintained. So we have to make sure we're doing neurologic examinations that reveal the level of the spinal cord injury. So spinal shock is a temporary neurologic syndrome. It'll occur in about roughly 50% of individuals with a spinal cord injury. They get decreased reflexes, loss of sensation, flaccid paralysis below the level of injury. It usually lasts less than 48 hours, but it can actually go on for months. Now, in autonomic dysreflexia, we have to remember that it can occur when spinal cord injuries are above the T6. This occurs after the period of spinal shock has resolved. Stimulation of sensory receptors, which are often due to distended bladder or bowels below the level of injury, causes vasoconstriction and hypertension. An increase in blood pressure stimulates peripheral nervous system, which will decrease your heart rate but can't stimulate the peripheral vasodilation that because of the injured cord. Now, we have to remember again, autonomic dysreflexia is a neurological emergency because this can lead to a hypertensive stroke. So some signs of autonomic dysreflexia is hypertension, and I'm talking about like up to 300 systolic. You might get flushing and diaphoresis above the level of injury, piloerection, headache, anxiety, nausea. So what we're going to want to do for autonomic dysreflexia is we're going to want to elevate the head of the bed to 45 degrees, notify the doctor, determine the cause, relieve any bladder distension, perform any digital rectal exams, and remove any restrictive clothing. So there are some plans of care when it comes to those with a spinal cord injury. Now, they might have an ineffective breathing pattern, ineffective airway clearance, or even a risk for impaired gas exchange because it relates to the paralysis of respiratory, chest, and abdominal muscles. So we want to make sure that they're going to be able to breathe independently at a rate of 16 to 20 per minute. Make sure that they're free of secretions and that their O2 will be higher than 90%. So in order to do that, we're going to maintain a patent airway. We're going to be prepared for any endotracheal intubation and mechanical ventilation if respiratory failure occurs. We're going to suction the airway to remove secretions and administer oxygen as prescribed. We're going to help the client use a spirometer as prescribed and encourage obtaining a pneumococcal, pneumonia, and yearly influenza immunization. They might also have impaired physical mobility, and this can be related to the loss of motor function. Now, our expected outcome would be that they'll be their ability to be mobile will be maintained. They can use assisted devices to move and perform activities of daily living, and that they won't experience any complications in relation to inactivity and immobility. So in order to do this, what we'll do is we want to position the client to avoid any contractures or foot drops. We want to help the client perform any exercises that maybe the physical therapist has ordered. We're going to want to apply leg braces whenever ambulation is possible, maintain their skin integrity and prevent pressure ulcers, facilitate urine elimination, keep the bowel evacuated, keep the client hydrated, and provide oral or enteral nutrition. We also have urinary and fecal impaction. And we want to make sure that that's not happening, because urinary retention and stasis can contribute to autonomic dysreflexia and the formation of renal calculi. With the bowels, if there's infrequent bowel evacuation, this can lead to constipation and impaction. So a high fiber diet and a bowel program using a suppository or enema every 3 days, approximately about 30 minutes after every meal, will normalize their bowel movements. They may also get some anxiety and risk for ineffective coping, and this could be related to the prognosis of their neurologic deficits. So we want to make sure that their anxiety is relieved, and some things that we can do is discuss information about the prognosis with the physician, tell the client and the family that determining the severity of deficits immediately after a spinal cord injury is difficult. So we want to explain the outcome that the outcome will vary depending on the specific injury and the response to rehabilitation. You also want to be a really good listener, offer encouragement as the client makes progress, right? So let's just remember that breathing is adequate to maintain oxygenation. So if pain is relieved or reduced to a tolerable level, we want to make sure that happens too. We want to make sure that they regain mobility using minimal assistive devices. We want to reduce the complications from inactivity. We want to make sure that the level of their anxiety is mild and that they're able to cope with the effects of their injury and the challenge of their rehabilitation. And we want to make sure that the client and the family demonstrate an understanding of the post-discharge home care. So let's go over this table really quick. So as we can see, the level of injury in a C1 to C3 injury, the most common motor effects are paralysis below the neck, impaired breathing, bowel and bladder incontinence, and sexual dysfunction. So basically that they won't have any sensation below their neck. So we really have to watch out for their swallowing ability, their speaking ability. They're usually going to breathe with the assistance of a ventilator, use a power wheelchair with movement of the head and neck control, things like that. Level of injury at C4 to C5, they might have shoulder elevation, and they might have need ventilation support. They're not going to have any sensation below the clavicle. Now, they're going to be able to breathe with a ventilator assistance and possibly independently using a power wheelchair with a sip and puff or a hand control. They're usually able to drink independently using a long straw and bottle. In injuries of C6 to C8, they might have some elbow, upper arm, wrist movement, and they can do diaphragmatic breathing. So they have some sensation in their arm and their thumbs, but there's some of the sensation in their chest is impaired. So what they can do, they're able to eat, groom, bathe, and attain bed mobility with assisted devices, but we might have to transfer from the bed to a chair using a slide board. They might be able to self-catheterize for males. It's a little bit more difficult for females. And they might be able to use a manual wheelchair in a flat environment. In injuries of T1 to T6, this is a paralysis below the waist. So they can control their hands and they can have abdominal breathing. So this means that they have no sensation below the mid-chest. Now, they can perform personal care and any kind of household activities independently. They generally use a manual wheelchair, including up and down curbs and a stand between bars with leg splints. In injuries of T7 to T12, these are varying degrees of trunk and abdominal control. So they have kind of varying degrees of sensation below the waist. They can transfer from the bed to wheelchair independently. They can propel the wheelchair or even over uneven surfaces and rough terrain. They can generally care for their bowel and bladder independently. They can kind of do light housekeeping and meal prep and balance on their legs. Sometimes they can walk with splints or long leg braces. In level of injuries at L1 to L2, their hip adduction is impaired. So that means that they have no sensation below the lower abdomen and some sensation in the inner thighs. So with their functional ability, they might be able to drive a car with hand controls. In level of injuries L3 to L5, they have knee and ankle movement that's impaired, and that means that they have no sensation below the upper thighs. Generally, they walk with a support of a walker or crutches. In an S1 to S5, they have varying degrees of bowel and bladder control and sexual function, and this means they have no sensation in the perineum. So they can walk normally without assisted devices, and they can also control their bladder, bowel, and sexual functions. So neuropathic pain is pretty long lasting and is generally really difficult to treat. So symptomatic pharmacotherapy is kind of like the mainstay of treatment. Currently, pain relief involves medications such as opioid and non-opioid analgesics, antidepressants such as duloxetine, which is Cymbalta, and that's usually known to relieve pain. Some anticonvulsants such as pregabalin, which is Lyrica, muscle relaxants such as baclofen, that's Lyrosol, antispasmodics such as tizanidine, which is Xanaflex, and topical lidocaine, which is Lidoderm. The results range from partially and transiently effective to totally ineffective, which has led to research for more efficacious treatment. So one of the approaches that involves the drugs that will target the glutamate release pathway. And another proposes a single spinal injection of fibronectin, a naturally produced glycoprotein that binds collagen, fibrin, and other proteins to cell membranes. So drug therapy can be combined with psychological treatments such as relaxation techniques, biofeedback, self-hypnosis, cognitive restructuring, and individual psychotherapy. So initially, the head and the back are going to be immobilized mechanically with a cervical collar and a back support. Then we're going to insert an IV line to provide access to a vein if shock develops. We're going to want to stabilize the vital signs. We're going to want to give corticosteroids, and this is going to reduce the spinal cord edema, which will then decrease the potential damage to injured nerves. We have a neuroprotective drug, which is called riluzole. And this is going to block the neurotoxic effects of glutamate that may be administered. Then we have Sethrin, which is a drug that promotes neuronal growth, which has been granted as a fast track status by the US FDA. It's shown evidence of promoting increased motor and neurologic recovery after acute spinal cord injury. So once the client is stabilized, the injured portion of the spine is then further immobilized using either a cast, brace, or surgical intervention. Traction with weights and pulleys is generally applied to provide correct vertebral alignment, and it'll increase the space between the vertebrae. Additional weight will then be added over the next few days to increase the space between the vertebrae and move them into correct alignment. A turning frame is then used to change the client's position without altering the alignment of the spine. So depending on the extent of the injury, surgery might be necessary to remove bone fragments and repair dislocated vertebrae and stabilize the spine. What will happen is the vertebrae are then fused with bone obtained from the iliac crest or stabilized with a steel rod, and we might have to do external immobilization with a brace or cast if necessary. So in spinal cord injuries, there's a long-term management. The focus of the treatment after a spinal cord injury is to make sure we rehabilitate them and restore what they had before, or as much as we can anyways. So there's something called functional electrical stimulation, and this can be used to activate paralyzed muscles and prevent muscle atrophy. It can be used in a variety of ways, and Surface or implanted electrodes will be applied to the quadriceps, hamstrings, gluteal muscles, and they'll help the paralyzed legs pedal a stationary bicycle, stand, or walk. They're attached to the forearm and flexors and extensors of the hand, and they can help open the hand and open and close to allow grasping of objects, reduce stiffness, maintain or increase range of motion, and increase circulation. It can actually also be used to restore bladder continence by stimulating the sacral nerves, causing contraction of the detrusor muscle necessary for bladder emptying. In addition, it can also improve breathing when the electrodes are implanted in respiratory muscles. They basically will reduce the need for mechanical ventilation. We also have treadmill training, and this is known as weight-supported ambulation. It's really only suitable for those that have an incomplete spinal cord injury. So basically the people that have remaining connections between the spinal cord and the brain. So treadmill training will increase the function within the remaining connections, and the client is suspended in a harness above the treadmill, and the therapist will move the person's leg in a walking fashion. Then we have tendon transfer surgery, and clients with injuries from vertebrae C5 through T1 will have weak or non-functioning wrists and hands and may benefit from tendon transfer surgery. It's basically a procedure that repositions tendons from a working muscle to a paralyzed one. So the goal of surgery is to restore a pinching motion with the thumb and flexion of the wrist. So the pre-surgical preparation and post-surgical rehabilitation are both pretty demanding for clients, and strengthening and range of motion exercises and physical therapy are pretty important. Then we have stem cell treatment. Now, nerve cells in the central nervous system, which includes the spinal cord, they lose their ability to regenerate when they're injured. So there's kind of a focus on finding cells that when they're transplanted, they can replace the nerve cells that have been damaged. Now, stem cells are pluripotent. That means they can differentiate into a variety of cell types, including spinal nerves. However, right now it's kind of politically and ethically controversial because some of the stem cells that are used are embryonic stem cells. Autologous stem cells from bone marrow have been collected from clients and reimplanted in the area surrounding the injured spinal cord with promising results, though. There are some researchers that are investigating the therapeutic effectiveness of using host stem-like Schwann cells and olfactory and sheathing cells harvested from the mucosa of the nasal tissue. So in surgical management, we can do boreholes, bone fragment removal, we can dislocate vertebrae repair, and we can stabilize the spine with a halo vest. Okay, so let's talk about spinal nerve root compression. So there are two basic types of spinal nerve root compression. We have the intramedullary lesions that will involve the spinal cord and extramedullary lesions that will involve the tissues surrounding the spinal cord. So the most common site of nerve root compression is at the level of the 3 lower lumbar discs. However, nerve root compression also will or can occur in the cervical spine. So pressure on the spinal nerve roots will result from trauma, herniated intervertebral discs, tumors of the spinal cord, and surrounding structures. Stress caused by poor body mechanics, age, or disease will weaken an area in the vertebra, which causes the spongy center of the vertebra, the nucleus pulposus, to swell and herniate. This condition is commonly called a slip disc. The displacement will put pressure on the nearby nerves. Pain along the distribution of the nerve root is pretty common, and actions that increase pressure will intensify the pain. We can get weakness and changes in sensations, and generally the symptoms tend to intensify when increasing nerve root compression. So in assessing this, symptoms can kind of vary depending on the cause of the compression and the level involved. So generally it will be weakness, paralysis, pain, paresthesia, When a herniated disc in the lumbar region compresses the sciatic nerve, the client will describe feeling pain down the buttocks and into the posterior thigh and leg. Physical examination will generally reveal weakness or paralysis of the extremity innervated by the compressed nerve. If a nerve in the lumbar or sacral region is affected, the client experiences pain when lying supine, so on their back, and lifting the leg without bending the knee. The pain will then increase when straining, coughing, or lifting a heavy object, and even walking and sitting become pretty difficult. So what we can do is we can do spinal radiography, CT, MRI myelography, electromyography, and that will show us a displacement or herniation of an intervertebral disc, tumor, or even bleeding around the nerve root. So when a client has a herniated intervertebral disc, generally we want to try to be as conservative as possible. We want to do that first. Metastatic spinal cord tumors are also treated pretty conservatively because the removal isn't really feasible. A herniated cervical disc is treated by immobilizing the cervical spine with a cervical collar or brace, and later, as inflammation subsides, the client will wear the collar or the brace intermittently when walking or sitting. Bed rest with a firm mattress and a bedboard is generally used for clients with a lumbar herniated disc. We can also do skin traction, and this can be applied in the home and used to decrease severe muscle spasms, as well as increase the distance between adjacent vertebrae, keeping the vertebrae correctly aligned, and in many instances relieve pain. So generally, treatment will relieve the symptoms for an extended period of time. We can do hot, moist packs that can treat muscle spasms. We can also give skeletal muscle relaxants such as corizoprotol and chlorzoxazone, which will help clients with a herniated intervertebral disc. We can also give diazepam, a tranquilizer that's used for its twofold effect, and that's to reduce anxiety associated with the pain of a herniated disc and also to relax the skeletal muscle. Drugs such as aspirin and other NSAIDs such as phenylbutazone and corticosteroids can also be used to treat inflammation, because reducing inflammation and muscle spasm helps to ease the pain, but the additional analgesics are used to control the pain. So with surgical management, we only go to this if after our conservative therapy fails to relieve the symptoms of a herniated disc, then this is when we consider surgery. There's a couple procedures for relieving spinal nerve root compression. There's a discectomy, and that's the removal of a ruptured disc. We have a laminectomy, and that's the removal of the posterior arc of a vertebra to expose the spinal cord. The surgeon can remove whatever lesion is causing compression. This can be a herniated disc, tumor, blood clot, bone spur, or even a broken bone fragment. We can do a discectomy with a spinal fusion, and this is a removal of the ruptured disc followed by a grafting of a piece of bone taken from another area, such as the iliac crest, onto the vertebra to fuse the vertebral spinous process. The bone can also be obtained from a bone bank. We can also do a chemonucleolysis, and this is an injection of the enzyme chymopapine into the nucleus pulposus to shrink or dissolve the disc, and this will relieve the pressure on the spinal nerve roots. So we have to remember that spinal fusion stabilizes the vertebra weakened by degenerative joint changes such as osteoarthritis and by laminectomy. So it results in a firm union, and the client will lose mobility and must become accustomed to a permanent area of stiffness. When a portion of the lumbar spine is fused, the client doesn't usually feel the stiffness after a short time because the motion increases in joints above the fusion. So motion is more limited when the area of fusion is in the cervical spine, and spinal fusion is also performed for spinal cord tumors, fractures, and dislocations of the spine and Pott's disease. So in spinal nerve root compression, the nurse is going to perform a neurologic examination, and we're going to note any kind of limitation of motion and the type of movement that causes pain. For clients that are being kind of treated conservatively, we're going to use a firm mattress or apply a bed board because a firm surface will support the spine and promote alignment. We're going to want to maintain the client on bed rest, placing him or her in a semi-Fowler's position with the knees and head slightly elevated. And this is going to relieve their lumbosacral pain. We can apply halo vest traction. For intermittent pelvic or cervical skin traction, we're going to attach the skin device to the client, support the weights, and lower them gently to avoid a sudden and strong pull. We have to remind the client to roll from side to side without twisting the spine. When the client gets out of bed, we have to reinforce the use of proper body mechanics and advise the client with cervical nerve root compression to avoid extreme hyperextension of the neck and side-to-side rotation of the head. We can also administer prescribed muscle relaxants and analgesics and apply moist heat for no longer than 20 minutes. We want to periodically evaluate their response to conservative therapy and note the activities and positions that increase pain and the gain or loss in motion or sensation since the previous observation. So generally, the nursing interventions after spinal surgery would be to monitor vital signs, assist them with hourly deep breathing exercises, but we want to avoid forced coughing because it will increase the pressure within the spinal canal. We want to examine their dressing for any kind of cerebrospinal fluid leakage, assess their neurovascular status, report an inability to void, and also help them with using a fractured bedpan. Post-operatively, how often should deep breathing exercises be done for a patient who had surgery for a spinal cord injury? A. Hourly. B. Every 2 hours. C. Every 3 hours. D. Every 4 hours. A. Hourly. Post-operatively, deep breathing exercises should be done hourly for a patient who had surgery for a spinal cord injury.